Welcome to DocPod. Hear Health.
Welcome to DocPod. I'm here with Dr. Daniel Stickler, who is the co-founder and CMO of Mosaic Biodata, as well as medical director of Quality of Life Sciences and the host of a podcast, Life of Excellence. And I appreciate you making some time here today, Dr. Dan. Thanks for joining.
Yeah, excited to be here talking about all the new and exciting stuff in medicine.
Yeah, I'm excited to have you. So, prior to the show, talked a little bit about some of the subject matter we're going to be covering here. Will be systems versus evidence-based medicine. So what are the AI implications in both, and where you see medicine in general, I think, going in both or either direction. Excited to chat with you a little bit about that. So maybe to get started, if you could, just maybe a high-level overview of comparison, evidence-based, systems-based, where they come from, what the transition is, where they're going, things like that, if you could.
Yeah, I'd like to kind of start with a little bit of a history of medicine. I mean, from early recorded history, we have medicine from Ayurveda and traditional Chinese medicine, which really looked at the whole organism of the human. And it looked at things that created imbalances and lack of harmony in the system. And it was about bringing everything back into harmony. This carried all the way through to the early Greeks, where they were looking at the four humors and the balance in the four humors in the system. But then in the later Greek medicines, they started getting more into analyzing the different organ systems within the body. And this really started us down that path of that reductionistic approach that carried through Rene Descartes and the Cartesian dualism, going through, germ theory and then the Fleckner report. And then in the early 90s, late 80s, we started seeing this term evidence-based medicine. And this was like, okay, we've got to have the scientific evidence behind each of these. But that actually was applied in the wrong way, because evidence-based medicine is highly valuable, but it's using a reductionistic thinking system to analyze a complex adaptive system, which is what the human system actually is. And that battle cry led to a lot of failures, even though it did lead to some advancements. But the failures, like the Women's Health Initiative that removed hormones from all the females for the last 25 years, that was misinterpreted by using evidence-based medicine and identifying the fact that, it increases breast cancer and heart disease, and there are no other benefits to it. Well, when you really analyze the data on a more individual basis, we find that that's not true. And so, countless numbers of women suffered through depression, development of heart disease, and increased their risks of dementia dramatically over these 25 years. I mean, it was a disservice. Same thing happened with the low-fat craze and the heart disease. You're seeing heart healthy stamps on Cocoa Puffs and things like that. That was the result of evidence-based medicine. Even the opioid crisis, when we identified pain as a specific symptom to be treated rather than looking at it as a complex system there. So what we're seeing is this evolutionary spiral where we're coming back around to looking at things from a more holistic level, and looking at the whole system and the balance and harmony within the system. And in the early 90s, systems medicine was really getting some good traction, but evidence-based medicine overshadowed it, and mainly because with systems-based medicine, it's a massive amount of data that you have to look at, and it's hard for a human brain to truly understand that.
And I think maybe with the development of large language models, with AI, with the now supercomputing of supercomputers, that data is able to be processed in the blink of an eye or quicker, especially from 30 years ago. And the leaps and bounds as far as innovation is concerned with big data analysis, I think has made systems-based medicine something maybe that's more achievable or even doable. And while it may have had its merits just as much in the early 90s, just didn't have the ability to do it or practice it well. Correct? Is that
AI
a
has
correct?
certainly changed the landscape and opened it up. I mean, and we need it more than ever now. I mean, with us getting data now on metabolomics, the full genome, transcriptomics, proteomics, the microbiome, all of this is new data that we have that is going to be interrelated in some way. And that AI can now handle that data processing.
I have a question. So, in regards to, so with evidence-based medicine, I'll give you an example. There's a patient in X hospital system in X city in X state, right? And they present with 2 to 3 different symptoms, and that physician or physician group has access to the EMR system within their system, right? So, but there's not really a lot of shared information across EMRs, across hospital systems with HIPAA laws and just medical information sharing in general. So, do you see an issue with that, with maybe the ceiling that's on top of information sharing within systems to systems-based medicine, because not all of that information is available outside of a particular system?
Yeah, I'm very passionate about the fact that I think individuals should own their health data. And I think this is where we can make the biggest impact. The individual owns the data. It's their dashboard. It's their database of them. And you have an agentic large language model that can look at their individual data and learn from that data, and then use that learning to apply N of 1 to other individuals without necessarily sharing their data. Without using their data in a public database. They're just actually using the learning from the data and using that. And that way, you've got the individual owning the data, the large language model that learns from that data, that can then use it to look at other N of 1 individuals and look at those relationships and feedback loops, what's working, what's not working for the individuals that have similar scenarios. That's the perfect world for me.
And so moving more deeply into that perfect world, if that was something that did exist, in addition to what you just mentioned, what else would exist in that perfect world as far as what the LLM or AI would have access to? How do you see this moving forward? What may need to change, actually, might be a better question for this.
Well, you need to build the right model. Right now, a lot of these health platforms are being built based on the evidence-based models. And so they're biasing the learning that the LLMs are the learning style that they're using to give the outputs and look for these relationships. You've got to build an LLM that is a complexity model rather than a complicated reductionistic model.
Mm-hmm. And so it becomes a little bit more preventative than reactive. And you can train an LLM or an AI to do pretty much anything that you want. You see with ChatGPT and almost any use that you can imagine. But the data itself still exists. So, do you think that you could push a couple buttons and take, a couple of months to train that LLM into a new systems-based model, or is it something that needs to be brand new created?
No, it needs to be built from the ground up because it's all based on the knowledge graph that you build for it. So a knowledge graph is basically somewhat of instructions, but it's looking at interrelationships rather than absolute values necessarily. So in complexity, you want to look at the most important thing is how data relates to each other, not the data point itself. And that is a whole different thinking system that would be required for building the program from the ground up.
And on that note, you made an analogy in an article that you wrote in March that struck me. It was very interesting. You said evidence-based medicine is akin to, you treat it like quality control in a manufacturing system or organization where everything works, but now everything is broken. It must be just this one piece that you have to fix, and then everything else will fall into place, as opposed to understanding that maybe the whole thing is broken, or it's a microcosm of this that affects this, that affects this. So what you just mentioned, talk to me a little bit about how evidence-based, how can the two be blended maybe? Can evidence-based medicine change a little bit into, or can the two meet in the middle?
That's the goal. I mean, we need to transcend and include evidence-based medicine into the model. So evidence-based medicine can give us suggestions as to what might be working, but then drill that down into those N of ones, looking at how an individual may differ from what's being shown at the population level when you average things. It's just like blood pressure medication. I mean, we have algorithms for blood pressure medication, which is, very reductionistic. It's like, okay, it's a white male that presents, then the first line of treatment are these specific drugs, because these are drugs that tend to work better in white males versus an African-American female. And this is still reductionistic because it doesn't take into account, what are the genetics of this person? What is the socioeconomic status of this person? What is the spirituality, the beliefs, the cultural systems that they're in? By taking those into account, you individualize that intervention for them. They may have genetics that says that they don't do well with this type of a blood pressure medication. Mm-hmm. And so the algorithm isn't looking at that. It's just going down through this stepwise pattern of the average in the population.
So makes it unbelievably antiquated, I think, evidence-based, as you talk about it in that manner. And I think a good example personally, I knew someone who was very close to me who was paranoid schizophrenic, and his physician, he was a lifelong chain smoker, but his physician said due to just the chemical balance or imbalance in his brain, he was very, very unlikely to ever get lung cancer. He may die of emphysema, but almost impossible for him to get that. And so the patient to patient, and I also knew someone who passed away from lung cancer who never smoked a cigarette in their life. Mm-hmm. So completely individualized and completely separate. But if you look at that without understanding it, you say, well, this person has lung cancer. This person is a chain smoker. They probably will get it because of this. So grander or greater implications of this moving forward. So where do you see medicine, or maybe where do you hope medicine is in 5 years, in 10 years, as AI continues to be smarter, faster, and implemented into multiple healthcare systems, practices across the country, and in pharmacologics and research?
Yeah, I see a system that's a single system that is translatable across all platforms. So a system that can be utilized by the individual, customized to the individual, like what is their motivation, what's their internal motivation, that will give them recommendations that will work within their intentional areas. But also that same system feeds into their system for their medical care. And the medical doctor, he doesn't want to have to go through all of this data, so he can have a dashboard that looks at specific criteria that they can look at quickly and see what's happening and see, motivators. So it would suggest, this person is intrinsically motivated in this area. This is the best way to approach them in eliciting a change in their behaviors or habits. And then taking that even further, you can take it up to the institutional level or the government level, where government policy can be looking at cohorts of people and say, this is the main thing that will move the needle in this realm of healthcare. And I think you can do that with a single system that feeds all the way through from individual up to government and institutional levels.
Now, at that level, it's do you see that being empowering for an individual patient once it does expand and put its fingers into everything from a family practice physician, excuse me, into the government in an entire system nationwide, globally? Or is it something that may end up being a hindrance just because the patient is no longer that much of an individual within that system, if that makes sense?
Well, they remain an individual at the individual level and at the physician level. They're N of ones. Everything's being looked at as an N of one there. But then at the institutional and government level, that's where more population or regional data can be drilled down. So what would motivate healthy behaviors in an inner city population versus what motivates behavioral change in health in rural populations? Mm-hmm. You can really kind of differentiate those and direct the policies in those individual groupings.
And so maybe on that note as well, if the wearables or if maybe the data inputs in some of the lower income areas and or places where it's not completely democratized, right, and everybody doesn't have access to even providing data to a physician. How do you see that changing? Is that just an education thing? Is that a policy where everybody should have X at the end of the day so that the data is available if and when they need to go to a physician?
Yeah, I think at the individual level, it should be something that at some point the individual platform should be available to all, and at a freemium or within their socioeconomic fee range, and have the platform really funded by the medical clinics and the government, where we're talking about money exchanges to save money at the government level or to increase revenues at the medical clinic through this, where they would be the ones that were really funding this program, but the individuals are getting it at a price that everyone can afford, depending on their socioeconomic status.
And maybe one step further to that. So if and when that were to take place, there's a nationwide physician shortage in almost every specialty. And you see physicians that are getting burnout and seeing way too many patients, and just maybe because of the requirement with insurance payments and, everything that goes along with that. Do you think that this will cause an influx in patients going to see their physicians because they now know that maybe something is wrong? They have access to their own data, and they're more educated, so they will go see a physician more. And what is that going to do to patient care with a limited amount of physicians to be able to see that many more patients, do you think?
Well, I think it's just the opposite. It will alleviate that, because one, you're going to have people that will be making changes because it's directed to them in healthy behaviors. And so you're going to see a reduction in the chronic diseases that people are presenting with. And As far as at the physician level, I think there'll be less visits, there'll be less intensive visits, and they will be shorter, more directed visits because they don't have to do all of the delving into all of this history and all that. It's brought together and they can actually ask the question of the platform and say, what might be some root causes of this insulin resistance that's happening in this individual patient. Mm. So it will be looking at the N of 1 contributors to why that person is doing this. So they don't have to go through this whole litany of discovery when it's being researched for them right there and then they can make the decisions quickly.
Now, how do you see, so if I have, call it 5 years from now, I have a wearable that has all of my data stored on it and or in the cloud from every physician visit, whether it's from family practice to a specialty physician, et cetera. Is that portable, right? Can I take that with me? Can I dig it into a physician's portal or whatever it is that they have? Is that something that's even possible? Does every system have to talk to each other?
One of the things that we're looking at is having it where the person owns their data, because your data that is held by a clinician or a hospital is not private to you. You don't have ownership of that. This is surprising to most people because that data can be subpoenaed very easily. And the physician is required to send every piece of data that they have. So what I would like to see is where the individual owns the data, shares specific data during the visit, and then removes access to that data as they leave. Then when they come to a follow-up visit, they can reshare that data, what was done on the previous visit, and so the physician has all that information at that moment, but does not have ownership of that data.
Well, that makes sense to me, and that sounds like an excellent idea. How far are we away from that, and maybe what's preventing that from occurring?
We're working on it. Funding is the answer right now. So,
so that's not necessarily something that's a regulation issue or a legal issue. It's just accessibility. Is that correct?
Correct.
Oh, okay. So when you say we're looking for funding, is there a stage in the process? Is there something that we might be able to look forward to as the patient population for this potentially to take place?
Yeah, Mosaic Biodata is our company that's really building this. I've been using the small scale version of this model in my clinical practice for the last couple of years. And I've developed my own little chat GPTs that are individual agents and working with this. But now we're looking at a much larger platform to do this processing, and it's going to require massive amounts of data to learn from. So we think if we can get this funding, our anticipation is within about 2 years we can have a pretty substantial working model.
Wow. That's unbelievable. And that time will fly, I think, as well.
Yeah.
Well, that's exciting, Dr. Dan. I'm excited to see where you're going to go with this and where your platform goes. And hopefully it's everywhere anybody can ever look within the next 2 to 3 years. I would love to see that, because this is something that I think that everybody needs, both on the physician side and the patient side. Will make, as you mentioned, patient care much more efficient. And much more personalized, and it's something that that the population needs in general. So both on a nationwide and a global scale. So I'm excited to see where that goes, and I appreciate you coming on onto DocPod and sharing some of this information and your knowledge with us, Dr. Dan. Thanks so much.
Thanks for having me. I appreciate it.